Hello, I'm Dr. Paul Hayashi, Associate Professor of Medicine at the University of North Carolina in Chapel Hill, Division of Gastroenterology and Hepatology. I'm senior author on the paper, Decreasing Mortality Among Patients Hospitalized with Cirrhosis in the United States from 2002 through 2010. The paper appears in the May issue of Gastroenterology. My colleagues Monica Schmidt, Sidney Barrett, Eric Orman, and I wondered whether or not the many advances in the care of hospitalized patients with cirrhosis have translated into better outcomes. For example, how we treat SBP, variceal bleed, and hepatorenal syndrome have all evolved over the last 10 to 15 years. Yet it's not clear whether these changes have had broad uptake or impact across the spectrum of hospitals in the U.S. Therefore, we ask the basic question of whether or not inpatient mortality for patients with cirrhosis has changed over time. To get at this question, we used the nationwide inpatient sample from the Healthcare Cost and Utilization Project. It contains a 20% sampling of U.S. hospitals, stratified by geography and hospital type. It's the largest all-payer inpatient database in the U.S., having over 71 million total discharges from 2002 through 2010. We focused specifically on the 750,000 discharges of cirrhotic patients and examined their inpatient mortality over time as a primary outcome. We also determined factors associated with mortality by multivariate Poisson modeling. Overall, the inpatient mortality for cirrhosis patients fell steadily by 40%. This decline was significantly greater than two control groups: non-cirrhotic age and gender matched patients, and age and gender matched patients with another severe chronic medical illness, congestive heart failure. Here you see the mortality rate over time. The cirrhotic cohort is represented by the falling black line on top. The two control groups are below in gray. The relative risk of death for cirrhotics also fell steadily to 0.5. Thus, a cirrhotic patient admitted in 2010 had a 50% lower risk of death compared to 2002. Remarkably, this decline in mortality occurred despite an aging population and rise in comorbidity index. In other words, cirrhosis patients were making it out of the hospital more and more despite being older and more complicated. Now, being older was independently associated with mortality, but the mortality rate fell across all age groups. Here again is the mortality rate over time, but broken down by age. The top line represents the oldest group, those over 80. The bottom line represents the youngest, those less than 40. When we looked at cirrhosis complications such as hepatorenal syndrome or variceal bleed, they were all independently associated with mortality. But they all had steady declines in mortality risk, except sepsis. The risk with sepsis actually increased. Here, the independent relative risk is shown over time. Hepatorenal syndrome is the falling gray line on top, and sepsis is the rising black line, also near the top. The reasons for this increase in risk with sepsis are unclear. So our study suggests that improvements in cirrhosis care may be paying off, at least in terms of inpatient survival. The data help validate the many studies that have changed cirrhosis care over the years. But our data also suggests that sepsis remains a significant problem. Cirrhotics respond to sepsis quite differently from non-cirrhotics, and therefore cirrhotics may need a more tailored approach. We hope that our data will help guide further research into cirrhosis care and encourage clinicians to incorporate cirrhosis care guidelines into their practices if they've not done so already. Thank you.